Hello, everyone. My name is Ricard Ferrer. I am the head of the ICU in Vall d'Hebron Hospital here in Barcelona, and I am also the president of the Spanish Society of Intensive Care. And I'm going to discuss about the pneumonia in the context of COVID-19. Those are my conflicts of interest. This is the typical case we have seen during the months of March and April. It's a 58-year-old male without previous condition that was admitted in the hospital because COVID-19 pneumonia was treated with the standard treatment in that month, together with antibiotics for community-acquired pneumonia. The patient at the beginning needs a high-flow nasal cannula during his stay in the ward, but additionally, he needs intubation or mechanical ventilation because acute respiratory failure and, of course, ICU admission. The patient needs a three-prong position for stabilizing, and then he presented several complications like respiratory infection with negative cultures, frequent mucus plugging with frequent bronchoscopy, a pulmonary embolism needing full anticoagulation, and the last complication was a ventilator-associated pneumonia. In this case, was by Klebsiella aerogenes, and as you can see in the X-ray and in the CT, it was a necrotizing pneumonia that need lung therapy. So this is the typical picture. You know that this is an experiment. You know that after 96 hours, in this case, after the inoculation of the virus, SARS-CoV-2 virus in a cell culture, you can see in these nice pictures that the cells express millions of virons after these 96 hours. That means that after this exposure, in this case in patients, we are going to have some patients that in fact do not develop infection, but patients of course can develop infection, and some patients will remain asymptomatic, but we are concerned about the patients that are symptomatic, and symptoms could be mild, moderate, and severe. And our concern, of course, is about severe patients that can recover, but a small percentage of them will die despite ICU admission. The reason for that is probably in the immunity and how the host respond to this infection. And some patients are going to have a deregulation in the immune response with hypercytokinemia, coagulopathy, and organ dysfunction. The most common organ dysfunction is the lung. This is the process of the infection of SARS-CoV-2 at the alveoli, and how is appearing some degree of inflammation with edema production, but also activation of coagulation and activation of coagulation in the endothelium of these alveoli. The treatment for this condition, you know, that is a combination of treatments, probably remdesivir and convalescent plasma. It's a good option for that, but also drugs that modulate the inflammation, like steroids, and maybe also monoclonal antibodies, and some patients need anticoagulation. And then the rest of the treatment is going to be supportive with mechanical ventilation, renal replacement therapy, ECMO, and some patients need vasoactive drugs. Which are the risk factors for this type of hospital-acquired infections? We have age, we have comorbidities, especially cardiovascular diabetes and COPD, because some of these conditions pre-activate the endothelium and makes that the COVID-19 infection is more severe, and then the patient is more prone to have these hospital-acquired infections. Prolonged mechanical ventilation, AKI with renal replacement therapy, and the immunosuppression associated to SARS-CoV-2 infection. You know that some patients present severe lymphopenia in the early phases, and the use of these immunomodulatory drugs also are risk factors for hospital-acquired infection. Those are the most common respiratory complications in my experience. As I said, mucus plugin, frequent bronchoscopy, tracheal perforation, like this case in this X-ray, and the patient is have an endoprothesis, and despite that, the patient dies, so it's a very severe complication, but also pulmonary embolism and thrombosis, pulmonary infarction, and the topic we are discussing today, bacterial pneumonia, that in some cases is necrotizing with MPMA. You maybe know that all the viral infections are a risk factor, in fact, for superimposed bacterial infections. The reason for that is that colonization of the nasopharyngeal together with direct mucosal and epithelial damage enhance bacterial adherence, and on the other side we have the alteration in the immune function of the host, and these factors together makes that it's easy that those patients with viral pneumonia have an additional superimposed bacterial pneumonia. Additionally, in COVID-19 patients, we have the use of these immunomodulators and also the high risk of thrombosis with hypoperfusion of the tissue, also the mucus production and the lymphopenia. So those are specific factors for COVID-19. In front of influenza pneumonia, we have more co-infection in influenza pneumonia, less co-infection in COVID-19 pneumonia, and then both of them are able to develop BAP. During the first months of the pandemic, Italians and Chinese investigators report an incidence between 31 and 65% of patients in the ICU requiring mechanical ventilation that have bacterial superinfection with a low rate of co-infection. In fact, all these studies were put together in this meta-analysis, showing that co-infection is affecting 3.5% of patients, but we are prescribing in antibiotics despite this low rate of co-infection in 72% of the patient, and secondary infection is around 14.3% of the patient, especially in those patients in the ICU. This is about antimicrobial prescription, and this data is from Michigan, showing that there is a lot of variability from center to center, but most of the patients, close to 90% in some centers, receive antibiotics. In most of the cases, it's for potential community-acquired infection, but in some cases also there is combination therapy for MRSA and Pseudomonas. So a lot of antibiotic pressure, and probably is not needed in all patients. And I also want to stress that in our experience, ECMO is needed in patients with COVID-19 pneumonia, ARDS, and in some cases because of this bacterial superinfection. And in our experience also, half of the mortality can be explained just because of this necrotizing pneumonia with MPMA. And as I said, despite ECMO support, 2 patients in our experience do not survive. The typical microbiology of these patients is a gram-negative bacilli, Klebsiella pseudomonas being number 1, but also Enterobacter, Serratia, and Acinetobacter are also involved. This is our local experience. Again, for us, gram-negative bacilli is number 1 with Pseudomonas and Klebsiella. Of course, we have some gram-positive cocci with Staphylococcus aureus and some fungi. But the important message is that 13% of the episodes of VAP in our experience is a necrotizing pneumonia, and in 30% of the cases, multi-drug resistant microorganisms are involved. Which are the risk factors for VAP in COVID-19 pneumonia? In our experience doing a propensity matching, we found that specifically corticosteroids double the risk of pneumonia in this population. However, we have to say that probably steroids, at least in trials, seems to reduce mortality, but we have to monitor in these patients very closely the probability of the lung infections. And in terms of mortality, again, propensity matching, you can see here that the mortality is 25% in the pneumonia group, 15% in the no-pneumonia group. So it seems that pneumonia is an additional factor for mortality and also for prolonged ICU stay. And probably the way we need to expand the ICU during these outbreaks, the outbreak we have in March and April, but probably also the outbreak during this autumn with these white space areas for attending in cohorts patients with COVID-19. Probably those are factors that can explain the high proportion of patients with multi-drug resistance. So my conclusions of this presentation is that bacterial pneumonia is a common complication of severe COVID-19 patients, and some studies report in fact very high mortality. Gram-negative bacilli is a frequent cause of pneumonia in COVID-19, and multi-drug resistance microorganisms should be considered in certain settings, as the last slide I showed you. Necrotizing pneumonia and emphysema can appear in some cases, and antimicrobial stewardship and infection control are essential elements in the management of these COVID-19 outbreaks. Thank you for your attention.